hit record again. Okay, so here we have a patient that is seen in the ear, nose, and throat department, and they have a preoperative diagnosis of a supraglottic mass, and they start to go through the patient encounter. And I'm not going to read the entire note, but I just want to give you the background of our patient. So they have this mass, and the procedure that they're going to do today is a pan endoscopy. Pan means total with the biopsy. So that's the first part of the note. Now, quite naturally, your patient is not gonna just come in and have a endoscopy. There had to be some type of office visit that happens first. Well, here is the office visit. So here, that's the first thing that should happen. This patient has a mass at the base of their tongue. And they've had a sore throat, which was getting worse, and it's been burning and all of that. And so you get to see part of the clinical record that we talked about before, the parts of the clinical record. So you have the history of present illness, you have the information about the past history, the patient's medications, their allergies, their family history, their social history, the review of systems, the physical exam. And then after that, more physical exam. And then after that, during this office visit, the doctor says, well, let's take a look. So they took a look and realized that the patient was not tolerating the mirror exam. And think of the mirror exam like when you go to the dentist, you know how they put that laryngeal mirror in there when they're cleaning your teeth. So the patient wasn't tolerating the mirror exam. They had an excessive gag reflex. And so they said that they need to do a more detailed exam. All right, so given that they have to do a more detailed exam, most insurance companies are gonna say, hold up, wait a minute, you can't just do this exam. What do you think the insurance company is gonna require?
Pre-authorization.
Pre-authorization. All right, so let's pause for a second and go back to the presentation, because again, I want to bring some of these concepts to life. So I'm going to talk about the scenario, but I'm also going to incorporate some stuff that don't apply to the scenario because I just want to bring some concepts together. So at our hospitals, one of the departments that are related to HIM, but not related, is the utilization review department, utilization management. And one of the things that the utilization management does is conduct a review of services, either before they happen, while the patient is in the bed, or after. So in our scenario, this is a situation where we have to get prior approval before the service is provided. So some of you called it prior authorization, some of you called it pre-certification, and basically we have to prove as a part of the prospective review process, we have to basically prove to the insurance company that this is a medically necessary service that needs to be provided to the patient. Now, my husband likes to say this statement, it's better to ask for forgiveness than approval. That doesn't go too well with the insurance companies, because if you do something and then, do an elective procedure and then come to them afterwards to ask for approval, what can they say?
Can say no.
It wasn't necessary.
They can say, no, it wasn't necessary, and then they don't pay you. And then who's going to pay for it?
You.
The patient.
Yeah, you, the patient. Now, in the Medicare world, you may have heard of a form called Advanced Beneficiary Notice, which is a form, ABN, that we give our Medicare patients when we believe that Medicare is not going to pay for a service. But on the commercial side, we don't have an ABN because that's a Medicare thing. So on the commercial side, we need to get their approval before we do anything outside of this office visit so that they will essentially give us authorization to provide it. So that's a prospective review. Now, concurrent is when our patient is in that bed and we want to continue to support that they need to stay in that hospital bed. Why would we need to prove that our patient needs to stay in that hospital bed?
Because the insurance company don't like to pay if they feel like the patient can do like a step down service, like don't need to actually stay there. But can
they want them to go home.
Yeah.
They want them to go home. So daily, the utilization review nurse or case management, they are required to make sure that the patient meets what is known as continued stay criteria, that patient continues to meet the criteria for that particular stay. And if they don't meet medical necessity for that stay, then that patient needs to be kicked out. An example of this is I was in the hospital after surgery, that surgery that I told you that I had. I was there, I was dehydrated. And at about 11:20, the day I was admitted, they came and told me that doctor said I was no longer dehydrated. They were discharging me. And they were doing that at that particular time at 11:20 at night, because at midnight, they would have crossed into another day, and they needed to make sure that they changed my status basically from a full admit to an observation, and they kicked me out. Now, the bad part about this for me as a patient, I was downtown Chicago, basically an hour away from home. I didn't have the nerve to tell my husband to come back and pick me up. So I had to take a cab in the middle of the night back home because they kicked me out. Because they knew that my insurance company was not going to approve that full-blown stay. So they kicked me out before midnight. So that was concurrent. And somebody was going to say something. I saw somebody going to turn their microphone on. Was it Lovey or Dee Dee? One of you. No, okay. So then we talked about concurrent. We talked about prospective. So then what's retrospective?
After the fact.
Yes, after the fact. So after the services have been rendered, they're looking at, was that really an appropriate hospital stay? It was an inpatient? Should it have been an outpatient? Should they have been admitted at all? So a lot of hospitals use criteria to determine if the patient meets the requirements for the hospital stay. So they're looking at, was the patient's illness severe enough to be admitted to the hospital? They call that severity of illness. Did the patient need intense services for that hospital stay? They call that intensity of services. So they're looking at, does the patient meet SI, severity of illness, or IS, intensity of services, for that hospital stay. So for example, if the patient has pneumonia and they can take some oral antibiotics and some oral steroids, do they need to be upstairs in a bed? No, they could be at home taking those. But if they need, if they're going to need IV antibiotics and IV steroids, then that's going to support that observation or hospital stay. Another thing about the retrospective review that you need to know is that it's also kind of like an audit where they're looking to see if there's perhaps some things that we missed in terms of our daily operational standards. You know, did we miss the medical necessity aspect? Did we miss the pre-authorization? So was there something in our daily operations that we didn't follow that we should have done? And hopefully that's something that we're doing internally, that we don't have somebody else that's looking at our stuff and saying, hey, you missed the boat on this. But from a retrospective review perspective, an agency that can do a retrospective review would be our state QIO. What's a QIO?
Quality assurance
Quality improvement.
organization.
Yes, our quality improvement organization. And so they are basically, you have one in every state, and they are the organization that give us our PEPR reports. You guys ever heard of PEPR reports?
Yeah.
So Google who is the QIO for whatever your state is, and then visit their website, and then you'll see everything that they do. All right, so let's go back to our patient.
I have a question about the continued stay report that the quality utilization review uses every day on the inpatient. Is that a universal document that they use on all patient types or just Medicare?
I'm not sure what criteria that they use across the different types. Because I don't generally work in inpatient settings. I know that they use criteria such as Interqual, Macmillan, but the specifics by payer, I'm not sure of what those are called.
Okay, thank you.
Anybody else work, Denise,
Yes.
at your hospital? What do they use? Do you happen to know?
I have a question,
For what?
Oh.
For continued stay criteria, what do you know what systems or tools they use?
No.
Because I know
No.
at one point your hospital was using some type of system, but I know in the past people have used to support inpatient stays, Interqual, Macmillan, but then nowadays there's these different systems. But then with Medicare, there's there are other dynamics that you have to consider too that are in the Medicare claims processing manual.
I have a question.
I'm listening.
When they do the retrospective review, is a major tool that they use, is that the MSDRG?
So no, MSDRG is a reimbursement methodology that we're going to talk about shortly.
Right, okay.
See, and that was my suspicion, that you guys were totally confused about these reimbursement methodologies, because I don't think that they're explained to you in a matter that your brain can remember.
Janina, yes. My
Janina?
question is, how far back you can do the retrospective? For example, I have, because since I work in a hospital, lately I've been seeing like visits that in the system it says it's inpatient, but in reality the patient had like a minor operation, not minor, it could be like DNC or hernia, and discharged either the same day, either the next day. But in the system it says inpatient. I know later on most of those cases are converted to outpatient.
And that's a major issue where that order is wrong.
Yes. So who, like, I know coders should probably catch it, but it should be part of retrospective review too, right? I mean,
yeah, but it should be, but as a part of the daily operation, somebody should be looking at that note concurrently to catch that. So that's where your CDI, your clinical documentation improvement specialist, should be catching it. So as a part of your operational practices, somebody should be catching it. It shouldn't be that QIO is catching it. Somebody should be catching it before.
Yeah, before they do, yeah.
Yeah, but unfortunately,
how far back they do the retrospective? Like,
I'm not sure how far back the QIOs will go, but I know that I've seen CMS go back 5 years.
Okay, thank you.
So, you know that old saying, well, not an old saying, but just because you got the money doesn't mean you get to keep it. So, like, how far back can the IRS go?
I know.
So, IRS is government and Medicare is government.
That's true.
John, you were going to say something?
No, I'm fine.
Okay. Oh, you asked about DRGs. We're going to talk about DRGs shortly. Okay, so let's say for our patient, we did a good job and we got it approved. Oh, when we call the insurance company to get approval, what information are we going to give them? Anybody knows? So for our patient who has and let me pull this back up. So our doctor, remember our patient, they have discovered that the patient has the excessive gag reflex. They need to do a more detailed exam. And so they have decided that they need to do this pan endoscopy, pan meaning total. So they're going to have to take the patient to the OR. So we have to get this approval. So the insurance company is going to want to know what's the name of the procedure. They generally want the CPT code. They want a diagnosis code, because what they're trying to do is establish medical necessity. And so we want that information to be as specific and accurate as possible. And one of the things I found in some doctor's office settings, that they don't have the appropriate personnel to do this process, and the people are just Googling codes and putting them on there. So we want to make sure that the information is accurate that we're giving to the insurance company, because if they don't think it's medically necessary, then they're not going to pay for the service. So we had the service approved. So then what happens next? After the service is approved by the insurance company. Think about this from an operational perspective. Scheduling, and they actually do the service. Okay, so after they do the service, and I want you to put your HIM hat back on. So after they do the service, what must they do immediately after the service?
Create the
Op report.
op report.
Yes, they have to create the operative report. Okay, so back to the handout that we have. So here, sorry, not trying to make you dizzy. Oh, where's the operative report? All right, so here is the actual operative report. So the patient has the supraglottic mass, and they tell you what the findings are and the blood loss and all of that. So the operative report is documented. What are the rules regarding the operative report? How soon does it have to be documented?
Immediately after the surgery.
Immediately after the surgery. Okay, so after the surgeon documents, then what happens next as a part of our revenue cycle?
Post-op check, no? And discharge.
Okay, then what happens next?
Bill.
We gotta code it. So the service has to be coded. So because this is, we're gonna call this an outpatient encounter, from a coding perspective, outpatient services would be coded with a CPT and ICD-10-CM. And HCPCS services, if any, would be captured by probably by the charge master. What's the charge master?
Where all the fees are.
Where are the fees are, and how do the fees get from the charge master to the claim form?
By coding using the correct CPT code.
Is it coding or is it the departments? Because coders, we do what's known as soft coding. Charge master is hard coding.
So it's like automatic when it go through the different departments, depending on what.
Yes, yes. So your laboratory departments, your x-ray departments, all the departments that are providing services to the patients, they use the charge master and enter a charge code, which then makes it onto the bill. Okay, so the coder is soft coding, and they're either using books or they're using some type of system. And if it's a Medicare patient and we have to consider medical necessity, what Medicare medical necessity policies do we have to review? What are they called?
LMRP.
Don't go old school.
National coverage, whatever the new name of for the national coverage.
Hey guys, anytime you hear anybody say LMRP, that tells you that they've been in the industry for over 20 years. So that's our running joke in the industry, because anytime we say LMRP, we know we've been in the industry for too long. So if we are working with the Medicare patient, and what I'm trying to do is just mix together concepts just to get them in here and be done with them. But if we have to consider medical necessity, and it's a Medicare patient, Medicare has a Medicare coverage database where they have coverage policies known as NCDs and LCDs. What you want to remember regarding these two types of policies is that NCDs are managed or maintained by Big Medicare. Big Medicare is CMS, the Centers for Medicare and Medicaid services. Now, why am I saying big Medicare? I'm saying big Medicare because Medicare does not have enough resources to carry out all of their day-to-day work. So the national coverage determinations, big Medicare, CMS maintains those, and then they have little Medicares do what are known as the local coverage determinations. The little Medicares are our Medicare administrative contractors, also known as the MACs. So if you don't know who your MAC is in your geographic location, here is a map of your MAC. So here in Illinois, our MAC is NGS, National Government Services. And let's see, I think John is in Philadelphia. So let me see, where's Philadelphia on this map? Is it up in the corner over there, or is it in the purple?
Purple.
It's in the purple, so you have Novitas. And let's see, where's everybody else from?
I'm in Georgia.
You're in Georgia, so I don't know why I'm having a brain fart today with regards to these states. Probably because I've been stuck in the house and can't get on the airplane, so I don't know where anything is now other than my mailbox. But you can see how, well, basically this is what happens. Medicare, CMS, big Medicare, they can't do everything that they need to do in terms of claims processing and all of that. So they contract with these little Medicares to process Medicare claims, Medicare Part A, Part B, and all of that. So that is the little Medicare or the Medicare administrative contractors. So big Medicare, they publish the national coverage determination. Little Medicare, they publish the local coverage determinations. I recommend that you go to the Medicare coverage database and pull up an NCD and pull up an LCD just so you can be familiar with what they look like. Because I think that, yes, knowing that the Medicare coverage database, NCDs, LCDs are all about medical necessity, but having seen one really helps with the recall analysis application. So if it's a Medicare patient and you have a medical necessity area that you need to review, this is the place that you would go. So an example, real quick, would be Medicare has a local coverage determination for routine foot care. And Medicare has specific medical necessity requirements that have to be met for routine foot care. And for those of you who don't know what routine foot care is, I haven't had routine foot care since March. It's like toenail trimmings and clippings and all of that. Medicare, so like a pedicure, right? Medicare says they will pay for routine foot care for Medicare patients if certain medical necessity requirements are met. And basically, the patient has to have certain conditions. So like if the patient has certain systemic conditions like diabetes and things like that, they'll pay for routine foot care. But if you don't have that, Medicare is not going to pay for that routine foot care. And that's because if a patient is diabetic, they're more prone to infections and the toes have to be clipped a certain way. And so that's what's contained in the NCDs and the LCDs. Well, since part of this domain covers fraud, well, some people got really creative and said, what we're going to do is to meet Medicare's requirements. Medicare used to have the diagnosis codes in the LCDs that supported medical necessity. And so what people were doing were going to the LCDs, seeing what diagnosis codes met medical necessity for the routine foot care, and putting those diagnosis codes on the patient's account, even though the patient didn't have that condition. So Medicare said, we're going to take the diagnosis codes out of the LCDs and put them into what they call billing and coding articles. And that's something that actually happened this year because of fraud. And, you know, why would you give the patient something that they don't have just to get paid is beyond me. Because remember, the codes are used to collect data. Oh, I got a question for you. What data bank do the Medicare claims go into? Starts with an M. MED. We talked about it last week. MedPAR. That's where those Medicare claims go to. And they're taking that MedPAR data and they're analyzing it. And they know if the Medicare patient is going to these several doctors, and only this one doctor said that they have this condition, that's how they can figure out that patient really doesn't have that condition. But anyway, okay, so let's come back. So the coder is trying to code the services, and the coder realizes there's some information in the medical record that is not clear. So what does the coder have to do?
Query the submission.
Query, yes. So as a part of this domain, one of the things that you should be able to do or understand is the query process. And I personally think, and this is why I have the who, what, when, where, and how, as a RHIA, you need to understand the who, what, when, where, and why regarding the query process. So we query the provider when the medical record documentation is unclear, it's incomplete. It's, we need clarification on something that they have in the medical record. AHIMA has a document, which I think is in your domain, one of your folders, but I'm going to check, not today, I'll check tomorrow, or not tomorrow, Monday. I will check to see if I have uploaded the query process into one of those folders for you. But you should read through the query process so that you understand what it's all about. However, I thought it would be good for you to see an example, because there are some do's and don'ts for the query process, such as we can't lead the provider. And leading the provider means that you can't just flat out tell them to document something. So here's an example of a query. So in this query, we say, the patient underwent this procedure. We noted that the creatinine was increased. The documentation states that the patient has this type of hypotension. This is what the creatinine was recorded as. So we're giving the doctor their information back. And it says the patient was documented to have an AKI, acute kidney injury. After study, principal diagnoses, can the patient's renal status be further specified? So we're trying to get further specificity. And we essentially give them a multiple choice quiz. And I'm pretty sure we talked about this last week, I think. We give them a other option. We give them an unable to provide additional documentation option. And then they're supposed to respond to us with regards to what their answer is. And we hope that they will respond. We hope. We're going to talk about more about the query process later, but this is what a typical query looks like. every facility has their own process, their own tools. Some places use a software, but this is an example that RHIA gives. Diana asked a question about LCDs and NCDs. So from a day-to-day perspective, you are always going to check to see if you have an LCD for your area. If you don't have an LCD for your area, then you're going to look for your NCD. And if you don't have an NCD or LCD, then there is nothing that you have available for that procedure for Medicare. So I highly recommend that you go to the Medicare coverage database and spend some time there. There you can get to the LCDs and the NCDs. And on this page, they actually have a, what do they call it? A guide to using the Medicare coverage database so that you're not just sitting there spinning your wheels. So when you get to the home page of the Medicare database, they give you that resource. Okay, so the coder has gotten the clarification because our doctor was good and he responded, and this is what the coder has come up with for the codes. Now, this is your coder. You are putting pressure on your coder to get the claims out. So the coder has gotten these codes, and your coder, those of you who are coders, don't say anything about what this coder has done, but you are the HIM director. Your CFO is telling you your coders are moving too slow. You've said that to your coders. So this is what your coder has done, and your coder has pushed the information through the system. Also, at your organization, your coders are using computer-assisted coding. What's computer-assisted coding?
Is that the hard coding?
3M, almost like a source to help them in codings like 3M. You know, I think it's an easier way of coding, but it is not an efficient way. If you ask me, they need the books. It doesn't, to me, it doesn't code to the highest specificity. Sometimes it leads you to the wrong code, but.
So
it's an extension of 3M software, and what it does is it recognizes the diagnosis within a document, and it picks the code, whereas the coder has to go behind it and say they agree or disagree, or they can find a better code. So it just scans through the document and finds the diagnosis to help, so-called help the coder out, because it's trying to make it automated.
Yes, so it automatically, so we feed the clinical documentation into the system, so it automatically translates the clinical documentation. It suggests codes. It's supposed to flag errors, and then the coders have to then come behind the system and make changes, which is counterproductive, because if we have to come behind the system and make changes, why do we need the system? But supposedly, has been said that it improves productivity. But if you get a group of coders in the room and you mention computer-assisted coding, they will beat you down. Diana, is that a true statement?
Yes.
Yeah, so you know, there's a lot of bugs that need to be worked out. I worked for a billing company about 10 years ago who had implemented CAC and was using a company outside of the US. And basically what the company was doing was just feeding the record into the system, and whatever the system told them, those were the codes that were put on the claim. And our denials just went through the roof, because at this point in time, the system cannot substitute for a human. I'm sure at some point it will get better, but it's not there yet. All right, so that's computer assisted coding. I threw that in there because on the curriculum guidance for domain number 4, you should have been taught about computer assisted coding in your program, because as an RHIA, you are responsible for creating policies and procedures to ensure proper coding. And if you have coders that are using computer assisted coding and they're not checking what the computer is doing, that's going to cause errors. All right, other tools that coders can use, or that our hospitals are using, ChargeMaster, we talked about it briefly. So the ChargeMaster has charge codes or department codes, which are attached to an item description for that service, which is then attached to a HCPCS code, which is also attached to a revenue code and a charge for that service. And this is why it's called hard coding. So the X-ray department, when they do a 2-view chest X-ray, they enter the charge code into the system, which then triggers the rest of this. So you don't necessarily at the hospital need a coder to capture 100 chest X-rays in a day, because the X-ray technician is more than capable of knowing that they did a 2-view chest X-ray, so they can put those charges in. Okay, so back to your coder. So your coder has captured these codes here, and then your coder has to do what's known as a charge entry process. So this is an example of a charge entry screen. And once the coder puts the codes in a charge entry screen, depending on the software, your coder should be hit with some type of edits. What are the types of claims edits that are out there today?
Edit.
NCCI. And what is NCCI other than National Correct Coding Initiative? What does it actually mean? What is it doing? Why do we have it? See what I mean? Beyond recall. We got to get to that analysis and application. So first of all,
correct. If we're coding correctly, it's like, I don't know how to explain it. It's almost like a crosswalk to say that if you do this, then this is the code for it, and it's the actual edit built in, because if it's not coded out that way, to kick it out.
Okay, so this is what happened. Years ago, doctors were trying to bill 2 services when only one service was required. So Medicare came up with a way to reduce situations like that. And they came up with this procedure to procedure edit table. So on this slide here, what you see is a column 1 and column 2. And it is doing a procedure to procedure comparison and making a determination if the code in column 1 is bundled into the code in, if the code in column 2 is bundled into the code in column number 1. And so what they do is, in this P2P, procedure to procedure analysis, is they recognize that there are some situations when these 2 codes may need to be reported together. So they have what are known as allowances, and they allow us to report these 2 codes together by allowing us to use what's known as a CCI modifier. So this column here, they tell us when a CCI modifier is appropriate. So in the legend at the top, whenever you see a code pair that has a indicator of 0, that means that there are no circumstances when Medicare, and this is a Medicare thing for the most part, other payers may buy into it as well, but we're not going to get into day-to-day stuff. But when there's a 0 across from the code pair, and on this example, there is no 0, they're all 1s. When there is a 0, this is indicating that there are no circumstances when they will pay for both procedures, okay? When there's a 1, they will pay for both procedures when there is a modifier that shows that this procedure is separate and distinct from that procedure. That would be like a modifier 59. So a patient has a lesion on their forehead that was excised, and then they have an adjacent tissue transfer on their nose, and you want to get paid for both of them, you will put a modifier 59 on one of them to show that they're separate and distinct from the other. So if there's a 1 next to that column, across from that column, Medicare is saying, yes, it's okay for you to report both of them. But if there is a 1 at the end of the column, Medicare or other payers are saying, we are only going to pay for the code that's in column 1 because they consider that to be the comprehensive code. So this is what the doctors were doing, guys. The patient needed to have their appendix taken out. And in order to get to the appendix, they had to cut up in the stomach, which is a laparotomy. So they were trying to charge for the laparotomy and charge for the appendectomy. Well, you can't get to the appendix unless you open up the abdomen. So opening up the abdomen is a part of the work of the procedure. So they're not gonna allow us to get paid separately for that. So this initially, this is funny how Medicare works, but this initially was all about physician services. And because this was doing so well, Medicare said, we're going to do this for hospital outpatient services as well. So if you go to, and I'm pretty sure I have this in the Dropbox file, but I'm going to add this to my list to double check. But if you go to the Medicare's website to look up NCCI edits, they have practitioner edits. That's for when you're working with the physician. And then they have hospital edits. That's when you're working with the hospital outpatient. This is not for inpatient. So speaking of, I asked you about edits, and the first thing that jumped out was NCCI, but that's not all. We also have edits for inpatient. So on the inpatient side, we have Medicare code editor. On the outpatient side, we have outpatient code editor, OCE versus MCE. Built into OCE is where you're going to see your NCCI edits. So MCE, that's inpatient, OCE, that is for outpatient. And in addition to looking for code pairs, what they're also looking for, guys, are things like, it's a female and you're trying to do a prostate procedure. So they're looking for a variety of things that should not be appropriate for that patient's claim. But what I will make sure I do, I'm going to give you examples of MCE and OCE, but I'm pretty sure in your textbook, when you get to that chapter, they'll have some examples as well, but I'm going to also give you some examples. And so in our system, we should have these edits built in to check our own work before the claim goes to the payer, so we can make sure that our claims are clean. So back to our coder. our coder is under pressure because you, RHIA, told her or him that you need them to get this claim out the door. So the coder got some edits. The coder got some edits saying, hey, there are some errors that need to be corrected, and the coder just ignored them and pushed those claims through to the insurance company. So here is a file called a live claims feed, which basically is a report that shows us all the claims that we actually pushed out. So speaking of claims that we pushed out, what are the two claim forms that we can use in healthcare? The two main claim forms.
UB04.
UB04? Uh-huh.
And the 1500.
And the 1500, yes. So on the professional side, we have the CMS 1500. And on the facility side, we have the UB04. So the 1500 and the UB04, that's the paper version of the forms. And because of HIPAA, they are submitted electronically. And when they're submitted electronically, they're called HIPAA something. So if it's the professional claim form, it's a HIPAA 837P. If it's a facility claim form, it's the HIPAA 837I for institution. So if we're talking about a Medicare patient, where does the claim go to?
It goes to CMS.
And what's the exact name of the organization that is processing the claims on behalf of CMS?
Is it that MedPop?
It's the MAC. Remember the little Medicares that do the LCDs? Well, the MACs, because big Medicare doesn't have the resources to process claims, our claims for Medicare are sent to the Medicare contractor. So the MAC is the Medicare Administrative Contractor. So they process Part A and B claims. What's Part A and B for Medicare?
A is hospital.
And B is for physician services. Yes. Okay. So the MAC, they get the claim and they process it and they tell us yes or no. And yes or no, what do they send us? I forgot to add this picture in. What do they send us after they process the claim?
UOB probably.
So they send us, if it's Medicare, they send us a Medicare explanation of benefits, and they send the patient a notice too, right? And they tell us how they process the payment, whether they paid us or not, and why they didn't pay us, and all of that. Okay, so another concept that is in the curriculum that you should have been familiar with is known as a clearinghouse. And the clearinghouse, anybody know what a clearinghouse does?
That's where the claims go.
Yeah, so it's like in between us and the insurance company. We push our claims to them, they scrub them up, correct any errors, and then send them to the payer. They get the clean claims to the payer. And if they're not clean, they push them back to us so we can correct them, or they try to correct them. Okay, let's take a 10-minute break. We're almost done. Let's take a 10-minute break because I don't know about you, but I had too much water today. So let's take a 10-minute break. I'm trying to get my 100 ounces in by 5 o'clock. All right, so let's continue. So we talked about the claim being sent to the insurance company. We talked about the clearinghouse. that is reviewing the claims and trying to get them cleaned up. But the reality is that not all claims are going to be paid. And that leaves us with a bucket of claims that are denied. And denied claims are those claims that are unpaid for a variety of reasons. They can contain beneficiary errors due to identification. So on the front end, our patient access specialist was collecting the demographic information and did not verify that it was correct. We can have coding errors. So coding errors such as diagnoses that do not support medical necessity. We can have duplicate claims. We could have a patient who has a surgery performed, and let's say they had a surgery performed 20 days ago, and today they have an office visit, and that office visit is a part of what's known as the global surgery package, and we should not bill for that surgery or bill for that office visit. That could be another reason why the claim is denied. Because if we're in that global period, that post-operative period, the insurance company is not going to pay us for that service today unless it has nothing to do with the surgery. The claim could be denied due to some type of NCCI edit, which, as you know, is under the, if it's an outpatient hospital service, it's under the outpatient code editor. If it's for the doctor's office, it's just the NCCI edit. And then there are other coverage issues related to insurance, such as we didn't get pre-authorization and we should have. It's something that's a part of the patient's plan or not a part of the patient's plan, like something that was cosmetic that they don't pay for. So there are a variety of reasons why they can be denied. Denials can also be divided into what are known as technical denials and clinical denials. So technical are usually errors that are like the payer's name, address, health insurance numbers, and usually with those, we can resolve those by appealing the claim. But then we have those claims that are denied for clinical reasons, and clinical reasons are generally like medical necessity. So, or not having pre-authorization. So contrary to what my husband says, it is not better to ask for forgiveness. You have to get pre-approval first. Clinical denials can also be coding related. It could be that, we queried the provider and they didn't respond and we submitted it as is. And so now we have to go back to the provider to get them to get on board. You heard me mention the appeals process. So it's a good idea to become familiar with Medicare's appeal process. They have 5 levels of appeal. You can Google their 5 levels of appeal. Medicare has a policy with regards to what the dollar amount is, with regards to what you can appeal. So like you wouldn't appeal for a $10 situation. But you can Google these 5 levels of appeals and what's actually required for the different appeals. So that was not covering the task for revenue cycle management, but something that I felt that I needed to cover because I felt like a lot of you did not have that foundational information. So as it relates to officially domain number 4, we will get to that when we get to domain number 4, but I wanted to give you that foundational information because as I was Oh, I was reviewing somebody's program that was going through reaccreditation, and I was looking at all the stuff that was in the curriculum that's supposed to be in the curriculum, and I said, I bet you the HIM, RHIA students, they probably don't know all this stuff, so I better add something to this class, which made me think about adding today. So, did you learn something today? I see Al shaking his head. What did you learn, Al? I see you shaking your head.
This information was more complete than what I had learned about revenue management on my program. It fills the gaps. It's like fill the gaps on what I have learned about revenue, the revenue on the program. It was good information.
So hopefully, when you read that chapter, then you can have this information in the back of your head. And then when we actually get to domain number 4, which you now have the slides for, and I may add some additional content to it, but I just feel like there's a lot of pieces that you guys miss when you're in the program. Miss Dee Dee, is that your name? Hey, your name is missing from the thing. Oh, Miss Dee Dee.
That's my nickname. It's easier. So, well, to me, this domain's important because it's one of the ones I did the worst in.
Everybody does. I believe every score report that I see, whether it's RHIT or RHIA, people do the worst on revenue cycle, and I just don't understand why.
I don't understand myself because, you know, I studied my weakest, the places that I thought were my weakest, but, you know, I'll try again. But no, I always struggled, even working in the clinic, understanding like the different type of payments. And even as myself, we have Cigna, so the whole deductible and the we have a deductible, and I didn't understand what was the point of that. If monthly we pay, you know. So this kind of cleared that up as to how deductible plays into having like the premium and that stuff. So
it's them getting richer.
Yeah, and us getting poor.
Yeah, pretty much, because I mean, they don't pay until we pay. So you know how, I don't know if in where you guys live, but here in Chicago years ago, there used to be these little signs in the grass. Health insurance, $89, right? And people would be signing up, but then the deductible was $5,000. Well, if you don't have $5,000 in services that year, you were paying that monthly payment of $89 plus paying for your visits, and they won. They win.
Yeah. So that was a big shocker. But yeah, I think this was helpful in understanding like seeing what revenue management does as a whole from beginning to end with the patient and behind, you know, doors as the coders and myself out on the front line collecting cards and all that. But yeah.
Anybody else? Hey, what happened to we lost a couple of people.
Dr. Campbell, I do have a question. Like the Latour book, when I seen even from the PowerPoints last week, and then this week, I mean, I know we're using the Oaks, but the chapters are corresponding with Latour. I mean, should we be using the Latour book as well?
Do I have the author's name wrong? I might have the author's name wrong. Wait 1 second. Let me just pull my book back up because I might have typed the wrong name down, but it's the bachelor's degree book, whatever their name is. I still call it Etna Huffman, but wait 1 second. Let me just log in.
That's the Oaks and Waters book.
So wait 1 second. Let me just make sure I have my chapter numbers correct. I was looking for my physical book and I realized I let somebody borrow it and now I want it back. Denise, you got my book?
Oh, no, I do not.
Oh.
I had borrowed from Charnice. I took it back though. I bought my own book. Since I got to read it, I need my own book to highlight in it.
So let me just double check. I'm pulling them up now. I might have had Latour on the brain. So, yeah, so actually the chapter numbers are correct. I just have the name correct. I have the name incorrect because chapter 7 is reimbursement methodologies. Chapter 8 is revenue cycle management. So, right chapters, wrong name. So I got to go through all my slides and put the ladies' right names on them. Oaks and Waters. Let me write that on my paper.
Which one is chapter 26?
Wait 1 second. Chapter 26 is
financial management.
Financial management. Yeah, healthcare financial management. All right, so we will resume next week on our regular time. But I wanted to add this on because I just had a suspicion that revenue cycle was a weak area. And I thought that foundational information would be good. So I'm going to update all the slides to say Oaks and Waters. Thank you for catching that. I don't know why I had Latour on the brain. All right. Well, anybody have anything else before we go? I rescheduled my exam for October 2nd. Hopefully it doesn't get canceled again, but the numbers in Illinois are continuing to climb. I tried to find a location in Chicago where the numbers aren't climbing, but I was just watching the news on the break. So hopefully my exam doesn't get canceled again.
I do have a question, Dr. Campbell, now that you say that. In doing the paperwork for HEMA, do you suggest one testing site over the other? Because I want to try to schedule like probably mid-October, end October, but what's your suggestion or recommendation?
You need to schedule now because
that's what I'm saying.
Oh, I would schedule whatever is available because somebody told me yesterday that the sites were limited.
Okay.
Right. They have nothing in certain sites past October.
Okay.
I've used Wells, Adams, and Rosemont. And Rosemont has nothing, not even in October.
I heard that there was some in Oak Forest, Illinois, but I definitely would get scheduled today. Because what did somebody tell me yesterday? Let me find Patrick's
I already
email.
got my dates.
So Patrick's scheduled September 28th at Oak Forest. It was pretty much the only date available, but he's in Indiana. But he basically said that was the closest, the date that he found available. So for those of you, whatever area you live in, I would definitely check your dates.
They're mostly weekdays too. I usually like a weekend. There's only weekdays.
They probably are already taken.
Yeah, there's nothing. There was one Saturday morning in Rosemont for 6 o'clock. I'm like,
AM?
AM. I'm like, you real now?
Oh my God. Well, at least your brain is fresh at 8 a.m.
My brain is not 6 a.m., not 8.
No, 6 a.m.
My brain is not fresh at 6 a.m. I'm still sleeping inside.
Oh, well, my test that I just rescheduled is not through a HEMA, but I'm an early test taker, and this place, they have this test at 2 p.m. I don't want to take a 2 p.m. test, but it was the only thing I could find.
My test is at 4 p.m.
Yeah, I don't like late tests because I'm not.
That's what they got.
Yeah. So for everybody, you should get your test schedule as quickly as possible before you don't have a slot. And remember, the test is changing January 1, and it's going to go into that beta, that 12 to 24 week beta period.
Do you register for the test through RHIA, or do you have to go through the actual testing site to schedule it?
So you go through, let me pull up the site. Wait 1 second.
Because it's been like 10 years since I registered. I don't remember the process at all. So.
And that's another thing that you want to check, because I'm assuming, oh yeah, I'm glad we're having this conversation.
So I'm
assuming that transcripts on file.
Right, that's what I was going to say. You got to send your transcript, request your transcript to be sent over first.
I already have a transcript, like an official one from the university that I've kept.
But RHIA needs to have it on file.
Right, and they don't keep it. I mean, I don't know.
I don't know, and I would not chance it. So I would definitely jump on it now.
So with the application, it asks like which university or whatever, and it says to send, like, do I send it? Do they send a?
Sorry.
You should send it electronic for faster processing. You have to depend on the mail. I wouldn't say fax.
Right, but where
I have to ask for my transcript from my school and just put the information of RHIA where to send the transcript, because they show you like during the application. So it has to be an official transcript. So you request it from your school and they'll send it like in 7 days, and then RHIA lets you know when they receive it. It'll show like a check mark next to that, and then they'll let you register for your exam.
So I'm on the RHIA website now, and if you click, on apply, they just recently updated the website.
It's messy.
Yeah, it's definitely different, but these are all the steps that you have to go through. So you apply on the RHIA website, but then you schedule your exam with Pearson Testing Center after they give you your admission to test.
Yeah, they'll email you saying, Pearson on the side saying that you could register, and they give you like an ID number.
This is a much cleaner explanation of the process. I actually like this revised website because it's giving you the steps. And I like that step 1 is read the candidate guide, because a lot of people didn't read the candidate guide. Let me see if the prices increase. That's what I was looking for. Hey, these exams went up, $329. Oh, that's the non-member price.
Non-member.
Okay. Yeah, I was kind of lost on the website because they recently updated the website, and some of the links I had saved no longer work.
Okay, so I have to apply through RHIA, pay, get the transcript sent over, and then go through Person View to schedule the actual date.
Yes.
Okay.
Yes.
When RHIA confirms your ATT.
Right, once I get the email back.
Now, I know that they have been doing a better job with those transcripts, because that was a huge issue previously, and I've heard that it's better. So, but I definitely would jump on it now.
Do you know if they keep the transcript? For example, if you already tried once, you send them the information, do you have to send the transcript again?
No, you don't have to.
You don't have to?
No.
They said it gives you a 120-day window. Once they get it.
But if it's more than 120 days.
Yeah, you probably have to resend it.
I didn't have to submit a new transcript.
I would double check, because RHIA has new administration and all of that. I wouldn't leave anything to chance.
Okay.
That's my personal opinion. I would not leave anything to chance. Especially since, it's basically September and you have until December, just in case. Always err on the side of caution. And the way this year is going, anything could happen.
Did you see on LinkedIn that Kirsty Bonner lady passed away?
Who?
Campbell Kirsty Bonner of LinkedIn. the one that's always doing like